All right. So I'll go ahead and give you both an introduction. Dr. Gibbs gave me his all nice and set up, so that was great. We'll start with Dr. Elliot since we're probably going alphabetically unless one of
Okay.
you has particular preference. All right. So Dr. Susan Elliot holds an undergraduate degree in urban and environmental studies combined with sociology from Brock University. And as well as I understand you got your PhD there?
No, I did my master's and my PhD at McMaster University.
That's what I thought, along with degrees in health geography from
Yeah.
McMaster. She is a medical geographer with particular interests in global environmental health. Susan applies transdisciplinary approach to her research on human impacts on environment-health relationships. She has undertaken a range of roles, including Director of the Institute of Environment and Health at McMaster, Senior Research Fellow in the United Nations at University Institute for Water, Environment, and Health, and I think I saw you became an assistant or an adjunct professor there as well. Dean of Social Sciences at McMaster University, as well as Dean of Health Sciences at your current position at University of Waterloo. She is the founder and editor-in-chief of Wellbeing, Space, and Society, the medical geography editor for Social Science and Medicine, as well as the Water, Health, and Sanitation section editor for the journal Water Security. She is also a research lead for the Allergen National Centers of Excellence on Gene-Environment Interactions and Allergic Disease. And, go ahead.
No. Stop.
And Dr. Paul Gibbs graduated as a veterinarian from the University of Bristol in England in 1967 and subsequently trained as a virologist/epidemiologist. His career has focused on the control and prevention of emerging viral diseases, a very interesting topic in today's climate, in animals, including those diseases that spill over to infect people. Once again, very relevant in today's world. He has traveled throughout the world investigating disease outbreaks, complementing his field work with vaccine development in a laboratory. For 10 years, he worked for the British government at the Pirbright Institute in England on diseases such as foot and mouth disease and rinderpest. In 1979, he joined the newly established College of Veterinary Medicine at UF, where he has worked on several emerging diseases that threaten the U.S., most recently West Nile virus encephalitis, and the discovery of influenza in dogs. He helped establish the One Health Initiative, which provides the global framework for addressing pandemic viral diseases. He has advised many organizations and governments on emerging diseases and is currently involved with the Food and Agricultural Organization of the UN and the World Health Organization for Animal Health in publishing rinderpest and its eradication. From 1994 to 1999, Paul was the director of the International Center at University of Florida. And I believe you're a professor emeritus now, which means you've retired from that position?
It means they don't pay me, yes.
Just do it for the love of the job at this point?
Something like that. Well, they occasionally give me mugs like that, you see, when you give talks. United Nations mug. That's what you get at this point, yes. But it's nice to be able to give back, actually.
All right. And I think, Dr. Elliot, you had some slides you wanted to share. Do you want to go ahead and try presenting? And I have them up if you have trouble.
Okay. And I share screen, so I can't present now. Will my slides come up?
They should, yes.
Yeah. Okay. Let's give that a shot. Present your entire screen.
Kelsey, do we know who the other person is apart from Taylor? Might they like to identify themselves?
They might not. Some people just come in to listen. So,
okay.
That's fine if they just want to hang out.
Will you allow GoogleMeet.com to see your screen? Yes. Nope, that's the wrong screen. Hang on. I gotta choose the other screen. Can't share your screen. Can you share the screen? Because I sent you my slides today.
Yep. Here, let me pull them up in present mode and then I will share those. There we go. You should be seeing them now.
Yeah, beautiful. You can just make it full screen, then that's full screen. Perfect. Okay, so I will just give you a next slide heads up for when we're, okay, great. Okay, so I'm gonna do them on mine so I can see them big. Okay, so what I want to talk about today are the Sustainable Development Goals. And in particular, I focus on SDG 6, safe water and sanitation. But my mantra is always 3 through 6 via 5. What that means is we will not have health and well-being for all, which is SDG 3, until we have safe water and sanitation for all, which is SDG 6. And in my view, we will have neither until we have women who are empowered, which is SDG 5, because water is quintessentially a gendered issue. What I also want to talk about is that it's not just what I do, but it's also how I do it. And hopefully that will become clear as I move through. So I did just want to identify that I am an adjunct professor at the United Nations University Institute for Water, Environment, and Health. I don't know how much you know about the United Nations University system, but this one is actually very close to me. It's actually about 15 minutes from my house. And they have a great internship program for for anyone on the session who's interested in an internship in water and health, have a look at that. So as indicated, I'm a medical geographer by training, and lots of people don't kind of know what that is. So I'm just going to start with a definition of that, because I think it's important to know who I am, what I do, and how I do it in order to understand my mantra of 3 through 6 via 5. So quintessential definition of medical geography, the study of the distribution, diffusion, determinants, and delivery of health and healthcare. When we talk about health, we need to be able to define what health is. And so in the olden days, we defined health as simply the absence of disease. If you didn't have cancer or heart disease, you were healthy. In 1958, the World Health Organization came along and said, no, it's more than simply the absence of disease. It's complete physical, social, and emotional well-being. That's what we mean when we say health. That's a bit of a challenge, though, because identifying and being able to measure all those things is really difficult. So is it a helpful definition? Conceptually, yes. Methodologically, it becomes challenging to measure that. My preferred definition of health is a definition that came in 1986 when the G7 at the time ministers met in Ottawa, which is the capital of Canada. And they developed a document called the Ottawa Charter for Health Promotion, Health for All. And at the time, the Minister of Health in Canada was a guy named Jake Epp. And so this is called the Epp definition of health, which is a resource for everyday living that allows us to manage, cope with, and even change our environment. And I like this definition because it's very active. But then we also have to define what we mean by environment. And I love Einstein's definition of environment, which is everything that's not me. And so we talk about the social environment, the physical environment, the political environment, the economic environment, the cultural environment. So there are all of these environments that are impacting on our health. My own research area is environment and health, and I look at 3 particular aspects of the environment. The first is the built environment, or how we construct the cities in which we live. And so we construct what's called a walkability index. This is a research project that we did in the major cities in Canada, in Vancouver, Montreal, and Toronto, our 3 major cities. And we designed this walkability index, which tells you how walkable is your city. And we combine 3 sets of variables to create a walkability index. And then we can actually analyze that spatially along with risk factors for health, like body mass index. So street connectivity, how well connected are the streets? Because if they're not connected, if they're all a bunch of cul-de-sacs, then people don't walk. The other is residential density. When you've got a lot of people living together in an area, people walk more than when they are living in a sparse area. And the other is land use mix. I love where I live because within 3 blocks, I can be on the main street of my small town, and there's shops, there's cafes, there's restaurants that I can't go into because it's COVID-19 and we are in a stay-at-home order where I live for the next 4 weeks. But normally, I like to walk there because there's lots of things to see and do. So that's the built environment and how it shapes health. The second of my research areas is what we call the socially constructed environment, or how we socially construct environmental risk. And so, as in my introduction indicated, I do a lot of research on food allergy. So we talk about the fact that, we see food allergies now that we didn't see before. We hear people say, every time you turn around, a kid has a peanut allergy now. There were no peanut allergies when I was a child. And we often refer to, in fact, the epidemic of food allergies. And we don't know where they came from. We still don't know what causes them. They're very low risk, but very high very low probability, but very high risk. Children do die from exposure to things like peanuts. Where did this come from? And so normally when I'm in a classroom in front of people, I would say, so what percentage of the population do you think has a food allergy? And Canada and the US are actually very, very similar. And the students come back and they say, oh, 50%, 60%, 70%. And I say, well, in fact, we've done the work. We've done 3 national surveys in Canada. And there's a woman in Chicago named Ruchi Gupta who's done very similar surveys in the US, and Scott Shisherer as well. We know, we can say with impunity, it's about 7.5% of the population. 7.5, not 50, 60, or 70. So where do these numbers come from? They come from a social construction of environmental risk. And a lot of people blame this on the media or popular culture. And it's interesting when you see things leak into popular culture. So this is a very popular TV show that's been on for a while with Tim the Toolman Taylor, who's a father of 3 daughters, and he doesn't like people, and he doesn't want to go to his neighbor's house for dinner. And so when he's making excuses to his wife, he says, just tell them we're allergic to everything, and so we can't come to their house for dinner. So using it as an excuse to get out of going to visit the neighbors. This is that new Roseanne show. I've forgotten what it's called now. The Goodmans, maybe? Anyway, in the very first episode, when this show was reborn, grandson comes home from school and says to his grandfather, he had a tough day at school. Oh, why is that? Oh, there's this bully and he's giving me a hard time. And his grandfather says, do you want me to do anything about that? And the grandson says, no, he's got a peanut allergy. I can take him out with a handful of trail mix. This was a huge media disaster, which was this remake of Peter Rabbit movie. And food allergic mums were apoplectic about the fact that in this movie, there was this character, Peter Rabbit, who was allergic to blackberries, and he was bullied because of his blackberry allergy. And so this got terrible media attention. This is a link to a show. I'll give you the slides after, and if you want to go see this, this is this show on, I think, US TV. That's What Would You Do? And so they put people in a situation where somebody is doing something bad, and they say, so what would you do about that? And in this case, this family saw that there was a group of young people, teenagers, sitting in a restaurant again, and a guy gets up, goes to the bathroom, and while he's gone, his friends say, oh, let's put peanuts in his salad, and then when he gets back, he'll eat the peanuts, and then he'll die. And so all the people around are asked, what would you do in this situation? This is Trevor Noah after the last major survey in the US, which showed that there was a very low and steady number of people with food allergies in the US, but a doubling of the number of people who thought they had a food allergy. So if you watch this episode of Trevor Noah, it's actually Trevor Noah saying, see, I told you they were all lying. They're all just making it up. So again, very bad press for people with food allergy. And this is just our most recent paper on the prevalence of food allergy in Canada. And so the way that we socially construct environmental risk can really impact our health, because when the situation is defined as real, it will be real in its consequences. People will make decisions as if they did have food allergies, if they think they do. And the way that we define food allergy, we've seen a lot of backlash against people with food allergies, and it really is a very serious public health issue. So that's the second area of research that I do. And the third is the physical environment. And I look a lot at climate change, but primarily at water, sanitation, and health in North America, Central and Southeast Asia, Sub-Saharan Africa, and in Latin America. So I really like this photograph. It's one of my favorites. This is a community that I've been working in for about 15 years, and it's in Kisumu, Kenya. It's right on the edge of Lake Victoria. Kisumu is the third largest city in Kenya. It goes Nairobi, Mombasa, Kisumu. And it just shows the multiplicity of uses. So, you know, Lake Victoria is the second largest freshwater body of water in the world, second only to Lake Superior, one of the 5 Great Lakes. And you've got people fishing in the lake, primarily for tilapia, which is a really important source of protein. You've got that child swimming in the lake or probably bathing in the lake. These guys who are standing on the edge of the lake are actually car washers. And during the day, what they do is they stand in the lake all day and they wash people's cars, and the people drive their cars right into the lake, including petrol trucks and garbage trucks and so on. And this lake is heavily, heavily contaminated, primarily with organic waste. And those guys who stand in the lake all day will often find themselves chronically ill with schistosomiasis. So you've got this amazing source of water. 30 million people living in the basin of Lake Victoria, heavily, heavily contaminated. And most people are just chronically sick and lacking access to safe water and sanitation. In 1972, there was a famous guy named Bradley, and he said, in terms of talking about how water impacts health, which is my major focus, that there are 4 ways that water impacts health. And the first way is waterborne diseases, right? So outbreaks related to water quality, and the pathogen typo is transmitted through contaminated water sources like typhoid or cholera, right? And these pathogens survive in the water, and humans generally need a very low dose of them to become infected. Am I actually changing the slides, or are you changing the slides?
I think it's me because I'm the one sharing the screen.
Okay, perfect. Are we in sync?
Are we on?
We're on the Bradley classification of diseases.
Yep.
Great. I just got so into what I was doing, I completely forgot where I was and what I was doing. Okay, so the next slide. So we're talking about cholera, which is a very unpleasant way to die and an incredibly preventable disease. And if you want to learn more about cholera, this is one of my favorite books ever written, which is Love in the Time of Cholera. Amazing love story that has cholera as the tie that brings a couple together. It's quite fantastic and it's amazing. And in fact, if you look at IMDb ratings about movies, the top 10 romantic scenes ever filmed, this is one that's included, and it's the romantic scene from Love in the Time of Cholera. So cholera even can be romantic, but it's a horrible way to die. And if you want to read about the geography of cholera, this is a fantastic book written by an investigative journalist in the UK called Ghost Map, and it's the story of Jon Snow and the identification of cholera in inner city London in 1854. So waterborne diseases are the first kind of disease. If we go to the next slide, and I'm giving you a trigger warning first, which is what I do in my class when I'm about to show you something that's going to be really uncomfortable. We also have water-washed diseases, when there's not enough water and personal hygiene is compromised. Diarrhea is an example of this. There's no water to wash your hands before or after defecating or cooking or whatever. And infections of the skin and eyes, like scabies, trachoma. Jiggers is another one, and these photographs are of a situation called jiggers. Jiggers are a flea that burrow under the skin, and it's because there's no water to wash with. And you can see how disfigured hands and feet get. This is a particular impact on young girls and women who are going to fetch water. As you know, women spend 2 million hours a year fetching water, and when they go to fetch water and they don't have any shoes on their feet and they don't really have water to wash with, these jiggers burrow under the skin, and the young girls and women become quite disfigured in their heads and in their faces, and as a result they're just not marriageable anymore. So this has huge sociocultural impacts beyond simply the fleas that are burrowing under the skin. And like schistosomiasis, this is not going to kill you, but it's really going to mess up your life. And on the next slide, we talk about water-based diseases, right? When a pathogen is transmitted through a host that lives in the water. Schistosomiasis is a good example. Those car washers who are standing in the water all day, constantly sick with schistosomiasis. And the challenge there is that really it's one pill, you're good to go. But those pills are hard to find, and you get no immunity once you've been ill. And what I've recently discovered is the tremendous gender-based aspects of schistosomiasis, because if you're a woman and you're standing in the water and you're bathing or doing laundry or bathing children, the snails can actually travel into your urinary tract and reproductive tracts and affect your fertility. And again, from a sociocultural perspective, if you're a wife that can't produce children, it has huge impacts on your self-esteem and who you are in that community. And the final one, of course, is water-related diseases like dengue fever, malaria, diseases that are carried by vectors like mosquitoes. The estimated burden of disease related to water issues is about 1.6 million deaths, but 105 million DALYs, or disability adjusted life years. What that should be telling you is that, you know what, yes, a lot of deaths, primarily in young children under the age of 5, diarrhea, malnutrition, dehydration. But if you survive that, you really have a lot of disability adjusted life years, which means that you're disabled in some aspect for a lot of that time. This has been recently updated by Bruce Houston and others, 2019, who do this about every 10 years. So a huge impact on global health comes from water. Next slide. What's interesting is that Jamie Bartram, who is a faculty member at UNC Chapel Hill and runs the Water Institute there, and used to run the Joint Monitoring Program for the World Health Organization, which is the program that tells us how many people have water and how many people have toilets. They recently wrote a chapter, next slide, which talks about a reconfiguration of these 4 types of illness. And I'm very proud of the next thing that's going to happen. It took me a long time to figure this out. So if we hit the next slide button one more time, you'll see what he's added to this table is violence. And this is the research program that I'm particularly interested in, is water security and gender-based violence. Next slide. So a scoping review of water security and gender-based violence, the violence that women experience when they are searching for safe water for themselves and for their families, or adequate sanitation facilities, or defecating in the open. So this is a scoping review of that literature done by one of my PhD students. And when we look at this, we see 31% of the papers uncovered looked at physical violence. So fighting, beating, spousal abuse for not having water in the house, stoning, sexual abuse, going for water early in the morning when it's dark or late at night when it's dark, or defecating in the forest, in the bush. So sexual assault, including rape, sexual assault, transactional sex for water. I'll give you sex if you give me water. Harassment, inappropriate touching, psychosocial health impacts, including stress and emotional harm experienced when meeting your wash needs. So, you know, being threatened of sexual violence or people making fun of you, and structural violence, including wash-related inequities and violence resulting from political or economic and institutional processes, like who has control over the household finances. Maybe my husband expects that I'm going to have water in the house, but I don't have control over the finances, so how am I going to make that happen? So what is the world doing about this? Next slide tells us that what the world is doing is we had the MDGs, the Millennium Development Goals. Although we didn't have a water-based goal, water was included in number 7 on environmental sustainability. It was a target under there, and we apparently met that target early for water, which I still have a little trouble believing. But we did not come anywhere close to meeting the target on sanitation. So then we flip to the Sustainable Development Goals. Now water has its own goal, right? SDG 6, and we have lots of great targets. But how are we doing on that? We've only got till 2030 and it's 2021. Well, last year, UN Water said, hey, we're not doing a very good job. We are alarmingly off track. At the current rate of progress, the world will not reach SDG 6 by 2030. Rates of progress dating back to 2000 show we've achieved, on average, 1% annual progress on expanding access to basic water supply and sanitation, but we need 3% just to ensure everyone has basic services by 2030. So we really got to step up our game. We're way behind. And then what happens? A global pandemic, where the most important thing you can do to stem the spread of the pandemic is to wash your hands. How do you wash your hands when there's no water? And so we have embarked on a research program. I'll tell you about that in a second. So my research program is focused on water health and well-being, but sometimes we also talk about water well-being and health. Does water lead to well-being and that leads to health, or is it water leads to health and that leads to well-being? We're still deconstructing those major concepts. We look at psychosocial health, we look at well-being, we look at dignity, and in particular, we look at gender. And from a gender perspective, we focus a lot on violence, on social capital, and on the empowerment of those women, because it's not just an issue of them accessing safe water and sanitation. They are completely or almost completely shut out of making management and administrative decisions around water and sanitation. So that's what we do, but I mentioned at the beginning that it's important to know not just what we do, but how we do it. And so I am part of what's called the Canadian Coalition for Global Health Research. And a few years ago, over a 5-year period, we developed a set of principles. They are on our website, and that link is there. They're also in the peer-reviewed literature. If you hit the next slide, you'll see a paper that was in Social Science and Medicine just a couple of years ago on these principles. And the principles are based in equity and how we actually do the research that we do from a global health perspective. And so what's really exciting, so the top photograph here shows the difference between equality on the left and equity on the right. Equity means that we recognize that we're not starting with a level playing field, and that if we don't do things differently, we're not going to make that playing field level. What's really exciting for us as researchers in the Canadian Coalition for Global Health Research is that this document here is the strategic plan for the Canadian Institutes of Health Research. That's equivalent to the National Institutes of Health in the US. They fund all the health research in Canada. They've just produced a strategic plan. In the strategic plan, they are recognizing and mandating these principles as part of proposals and review processes. The next slide shows you what those principles are. And I won't spend a lot of time on that. You can go and look for yourself. But just to point out that the foundational principle is equity, or the foundation for the principles is equity. And we talk about authentic partnering. We talk about inclusion. We talk about shared benefits. There has to be something in it for the partners, not just for the researchers. There has to be a commitment to a future, not just a one and done. We are responsive to the causes of inequities. So let's look at those gender issues that are causing the inequities in access to safe water and sanitation, and not just try and provide water to people. And finally, humility, which is very difficult for us as researchers to go in saying, we don't know, you tell us. And the next slide just tells you a little bit about our team and what we're doing and the population that we're working with. So we're working with seniors in Uganda, with mothers in Kenya, with marginalized populations in Brazil, with the homeless in Mexico, and with low-income communities in Ghana. And what are we measuring? We're measuring access to safe water and sanitation during times of COVID. We're measuring aspects of water security and gender-based violence. And we're measuring the EWI, which is the Empowerment WASH Index, which was developed by my young colleague, Sarah Dickin at the Stockholm Environment Institute, and my young colleague, Elijah Bissung at Queen's University in Canada. This was developed in partnership with the REACH program at Oxford University and has been piloted in Burkina Faso and Ghana. So we are now going to take it to these other communities, and it measures levels of empowerment in women to actually make decisions about water and sanitation. We hit the ground running with this in March 2020, and we will be in the field hopefully by the end of this month. Why? Because it takes a long time to get research ethics approval to do this kind of work. We do have stuff that's going on in Brazil and Mexico, and we have some amazing data about how we're dealing with homeless populations and low-income populations in the face of a pandemic in two of the hardest hit countries. And in Ghana, we're beginning to get data done there too. Our take-home message is we want to be able to empower women so that we can address SDG 6 and in the end have health and well-being for all. And what we want to do out of the COVID pandemic is to bounce forward and not back. And if you go to the last slide, it's a picture of a beautiful sunset over Lake Victoria in Kenya, because I'm a geographer and geographers always end their slideshows on a pretty sunset. And that's the end of my presentation.
Thank you so much, Dr. Elliot. I really enjoyed those slides, and I really enjoyed particularly because our panel is about the SDGs and that we are a chapter of the United Nations Association, that you tied it in the other SDGs, because the entire point of them is that they are so intersectional.
Yeah, for sure, for sure.
All right, Dr. Gibbs, you want to go ahead?
Sure. Shall we see if we can try it from this end first?
Yeah, go ahead and give it a try, and if not, I will open up the Dropbox while you're giving it a go.
Let me just open this up. Reduce that for a moment. That's interesting. I'm seeing 3 of you at the moment. Yeah, I've used Google Zoom, Google quite recently, but it doesn't seem to be. Let's try this. What are you seeing there now?
I see Paul Gibbs is presenting, and I see a mini version of us.
It's interesting. So how did that come about?
It looks like you shared a window, but you shared the Google Meet window.
Yeah, let's stop presenting again. All right. So we'll do present now, and we'll do your entire screen. And let's do that one there.
There it goes. Now I see the slides.
You can. Okay. So let me see if I can reduce that and bring up that one. Okay. So how is that? The only thing I cannot see at the moment is any of you, which is the way of life.
Looks good. Looks good.
But we'll come back to that later. And don't be worried by the number of slides here. I'm going to go through it quite quickly. Susan gave you a very good background of the importance, obviously, of one component in terms of the epidemiology of disease, and that is water. And what I'll be talking about is actually not so much the terminology of global health, although that comes into it, but I'll be talking about One Health. And I don't know how much any of you know about One Health, but One Health is supported very much by the United Nations. It's supported by the World Health Organization and also by the Food and Agricultural Organization. And those are respectively in Geneva and then also in Rome. So I've chosen to tell you a little bit about how One Health really supports the goals of the United Nations. So I think you already know a little bit more about me. All that I want to tell you really is that food security and poverty alleviation is something that I've had an interest in for a long time. I chair a number of committees, particularly in Europe and the UK, that deal with zoonoses in emerging livestock systems. And quite often that very much brings forward, as Susan was explaining, the importance of women in terms of agriculture and then also in terms of health. So why do I put Coca-Cola here? Well, when I was the director of the International Center, we basically had a philosophy that in terms of the US, wherever Coca-Cola was, then our students should be. And through that, and through a very interesting serendipitous meeting with the director of the Foundation for Coca-Cola, we ended up being able to have students associated with international organizations like UNICEF, Save the Children, etc. And that might be something that you could look forward to, at least in Champlain, is looking at ways in which you can get industry to support you. I'm not sure that Coca-Cola in Atlanta would necessarily like to see their name on this particular hotel. This was actually a photograph out of Kenya. So let's look at the SDG 3 and the targets under SDG 3, which is good health and well-being, is essentially running the gamut from maternal mortality right through, obviously, environmental toxicity and things of that nature. But target 3.3, which is fighting communicable diseases, is the one that obviously I have the most interest in. And also, if I can say I have any expertise, it is in that particular area. And COVID-19, as Kelsey pointed out, is very much exhibiting all the features that means that SDG 3 has, in fact, very much a focus on disease, and that at the moment, the challenges of COVID-19 in terms of vaccines and things of that nature are immense. But as I mentioned when we were chatting before the talk started, we should now, with the marvelous introduction of these vaccines, we should have the opportunity to control COVID-19. And in fact, I would argue that we could even eradicate it. But that's a discussion we could perhaps have later. So let's hope that we can move from this stage of the world being masked up to, in fact, through vaccination, a world free of COVID. So what is, or why is the World Health Initiative relatively important to SDG 3? And that's what I will talk about initially, and then I'll move forward into some good news. And that is that we have been able to eradicate 2 diseases that have relevance to, in fact, the goals. I'll talk a little bit about some of the drivers and the challenges that we face in terms of controlling diseases, and then we'll end up with a take-home message. And while we are looking at SDG 3, I would have to point out that obviously number 1 and number 2, relative to infectious disease, also have relevance. So what is One Health? Well, One Health was a term, a concept that came into play around about 2004. And it's now gained quite a lot of traction, both within the medical and the veterinary fraternities, and also by environmentalists. And it's a worldwide strategy, really, for recognizing that we all need to work together much more. And also to emphasize that communication is critically important if we are to promote health. And Susan has, in fact, identified that the original definition of health by the World Health Organization in 1948 is, in fact, a lot more than just freedom, certainly from infectious disease. And it's a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And Susan went on to say that there, in her view, there's an improved definition. And thank you, because I wasn't aware of that. And under this umbrella of One Health, we have what originally was One Medicine, which didn't take into account the environment to the same extent. And now we have various different topics such as molecular epidemiology, et cetera, et cetera. I mean, John Snow would be really proud to see what epidemiology has actually grown into. Well, this may seem a little bit, how could I put it, challenging, that we should recognize that we have mega concerns of 2021. And how does that, in fact, relate to the concept of One Health? I would argue that this millennium, for many different reasons, is really presenting a very uncertain future for all of us, and particularly for young people, because young people like yourselves are likely to be in your respective professions for the next 50 years. And one would have to say there's a lot of political instability at the moment, but also we've got the challenges of pandemic disease. And the other aspect that I want to point out is that we have food insecurity. And food insecurity in this context obviously means shortage. And we know many of the different reasons why we may be in this situation. We've got ecological disruption, we've got climate change, and we've got population growth. And we'll address some of those in the next few slides. Well, this gives you, as one single cartoon or series of photographs, the epidemics that we have faced really since 1983. And that was when AIDS was first recognized. And since that time, we've recognized that all these different diseases here, with the exception of equine influenza and canine influenza, are actually zoonotic. So in other words, they have come across into the human population and in many cases have become firmly established, such as we've got with COVID-19. And they therefore represent zoonoses. And the importance, in fact, of emerging diseases was recognized by Laurie Garrett. And for those of you looking towards different types of careers, you might like to recognize that Laurie started off as a science a PhD student. In fact, I think she's got her PhD. And then she became a journalist. And she was able to point out that, in fact, emerging diseases were going to represent into the new millennium a real challenge for us. And she was absolutely correct. And by 2004, we were recognizing, in fact, that avian influenza was emerging out of the Far East, and it was literally killing millions upon millions of poultry. But more importantly, it was also killing people, not in great numbers, but it was recognized that this represented a challenge because everyone's mind goes back to the Spanish influenza pandemic of 1918, when perhaps 50 to 100 million people died around the world, affected mainly young people, in fact. And at that time, the world population was probably about a third of what it is today. And at that point, FAO and the World Health Organization recognized that they needed to work together. And a concept had been advanced by a number of us called One Health, which was this interdisciplinary approach. And FAO and WHO recognized that this had great value to them, and they therefore promoted One Health. And now we find that many different organizations have the ethos of One Health, including the World Bank, etc. And research and disease control programs are in fact structured then within the One Health paradigm. And at that time, I had the good fortune to get into Vietnam, and I began to realize from that how complicated understanding avian influenza was and the way it spilled over into people. And in that context, I want to point out that the rural environment, much the same as Susan pointed out in terms of Kenya and Lake Victoria, how often the communities use water in different ways, particularly here in the rice paddies, and how ducks and chickens interact, and how disease was able then to perpetuate itself in this endemic situation. And from that, we were then able to, the FAO was then able to look at the different sectors as they contributed to, in fact, highly pathogenic avian influenza. And they began to recognize that, in fact, this represented a pandemic threat. And from that point on, then looking at One Health, we could recognize that we had to be looking at bird migration. We had to be looking then also at the cultural practices. And only through that could we begin to realize or to recognize how we could control this disease. And if I go back one slide, I would point out that if you are looking, for example, at ways in which this virus could have been introduced through bird migration into the United States and Canada, then it was actually through the Arctic migration routes coming down into Northwest Canada and then down into Alaska and then into places like Washington, etc. So we therefore focused our attention in that part of North America to address these issues. And what happened in 2004 was that it emphasized to us, in fact, the importance of wildlife as reservoirs for human disease. And that had been preceded, obviously, by the recognition of SARS, severe acute respiratory syndrome in people. And since that time, we've recognized that there are many other diseases that, in fact, have a wildlife host, including Ebola and Marburg. And that would take us to a discussion of Uganda, but we can leave that perhaps until the discussion later on. So I mentioned to you the mega concerns of 2021 earlier, and let me now just address food insecurity for a moment. And in 1980, I was privileged to put together an edited 2-volume book that looked at virus diseases. And it was called, actually, and Susan might be interested, A World Geography of Virus Diseases at that time. And I pointed out that, in fact, the veterinary profession had a responsibility to obviously produce food. And mindful of the fact that in 1798, Jenner published his work on vaccination. But in 1798, Thomas Malthus pointed out that he lived in Surrey in England, about 100 miles away from where Jenner was. And he pointed out that, in fact, at some point, the world population would increase to the limit of the productivity of the land. And if we look at population dynamics, we can see that the world population is going to be increasing until about 2050. Now, the rate at which it's going to be increasing is leveling off, but nevertheless, we're going to probably get up to about 9 billion, or in fact, somewhat more. And if we were to look at different countries, we can see that the balance between some of these different countries is quite different from what it is today. And if we were to take, for example, India, that would become the most populous country. On the other hand, China would be third in terms of ranking, and Nigeria would have overtaken it. So what we have to recognize, however, is that this world population has to be fed. And I think this is quite a dramatic slide in many ways, and it's one that really makes us think. And this was a quote from Catherine Moteki, who pointed out some years ago, in fact, 2012, that over the next 50 years, we will need to produce as much food for the world's population as has been produced in the entire history of mankind. And when you think about that, that is quite some challenge. But more than that, that population itself, of course, is now, because of the density of the human population, is much more prone then to become fuel, if I can use that phrase, for a pandemic. So it's likely that for various reasons, we will in fact see other pandemics within the near future. And I think Laurie Garrett, going back to her comment earlier on, that the coming plague is still very much pertinent today. So let's talk about some good news. The good news is that smallpox, this horrible disease that killed off about 30% of the population of Europe in the 1700s when Jenner was doing his work, was eradicated by the vaccine that Jenner produced in 1798. The same vaccine essentially eradicated smallpox by 1980. And then using a vaccine, a different vaccine, obviously, from the one that Jenner used, because rinderpest is caused by a virus related to measles in people. Rinderpest was eradicated in 2011. And there's a nice quote that goes from the time when this disease ravaged East Africa. In fact, the Maasai at that point were the dominant tribe in Kenya, but so many of them died of starvation. They also were affected by smallpox at the time, that in fact the Maasai at that point pointed out that there were so many dead cattle and they were so close together that the vultures had forgotten how to fly. And I think that is a beautiful expression of how dramatic and sad that event was. And rinderpest kills about 80 to 90% of cattle, and cattle are so important to many tribes within Africa, and obviously cattle are important worldwide. And the books have come out on smallpox, and just last week I was reading the proofs for rinderpest and its eradication. It's taken us about 8 years to get to this point, and that should be coming out later this year. But there are two other diseases that the World Health Organization has proposed should be eradicated and has been working to that effect. The first one is polio. They've been working with, obviously, many other different agencies, including Rotary International. And we're getting to the point now that polio is only in 2 countries. It's in 2 countries of Asia, that of Afghanistan and Pakistan. There are some problems with vaccine reversion, which I don't have time to go into today, which we're seeing in Africa. But the good news is that polio is on its way, we hope, to global eradication. And obviously, polio takes us back to water because polio is transmitted generally in water. The other disease that we had hoped by now, and we is the big international body of disease control experts, is that using vaccines, once again, that essentially it was hoped that measles would be eradicated by 2020. Unfortunately, that has not happened, and we've had resurgence because of vaccine hesitancy, and particularly even here in the United States, because at one point, the region of the Americas was actually declared free of measles, but because of international travel, etc., the disease has reemerged. And the big concern at the moment is that now children are not getting vaccinated, largely because of all the problems of lockdowns, etc., with COVID-19. So now let's talk quickly about drivers of emerging and pandemic diseases. And we don't have much time to talk about this in detail, and I'm sure most of this is pretty obvious to you. Once we had the jet engine, we were in a position then literally to see people and goods moving around the world literally within 24 hours. I know that if you're stuck in Chicago trying to get down to Atlanta or something like that in the middle of winter, you won't believe that. But that's the reality of it. And of course, that's within the incubation period of diseases. And this means that a person could be incubating disease, come into a country, and only when they arrive in the country will they then be transmitting that disease. We also recognize, because of the pressures of human population, that we're getting more and more into the forests of whether it's Brazil or the Congo, and we're exposing ourselves, in other words, the human population, to viruses that hitherto we were never exposed to, or if we were exposed to, then there would be a little outbreak and it would die out because it didn't have the means of exploding out through air transportation and things of that nature. And just think of how the disease got out of Wuhan. It was essentially on an airplane. So let's give you a few little examples, and we're going to really be talking about just the coronaviruses. And we can, as I said, if we want to, talk about Ebola when we come to question time. 2003 was when severe acute respiratory syndrome, or SARS as we now know that, emerged. And it was a surprise for us as virologists, because most coronaviruses, and we've known about coronaviruses for a long time, most of them are associated with mild respiratory disease in people. And in animals, we see it causing both respiratory disease, but also we get a degree of enteritis. But this disease came out of an international airport. It was Hong Kong. Canada was particularly badly affected because a super spreader arrived in Toronto. And that was the first time for a long, long time that around the world, people started thinking of quarantine for human populations. It had gone basically into dormancy. And the word quarantine comes from quarantino, which is 40 days. And that was the period that boats, if they were carrying cholera, had to stay off the port of Genoa before it was allowed to dock. And a lot of us thought at the time that SARS would reemerge. But before it did, it spread around the world. It was controlled, and then it died out. And it didn't have the transmissibility, obviously, of COVID-19. And it was fairly quickly realized that food handlers, using simple epidemiology, were overrepresented in the early cases. And remember now the focus that's happened with Wuhan, that it was on that wildlife market, or that seafood market, which also had wildlife early on. And from that, we began to realize that probably the reservoir, at least within the markets, was the masked palm civet. But once we got molecular virologists involved, it quickly became realized, no, that wasn't necessarily the full story. And then the trail led back to the Chinese horseshoe bat. And then, after about 8 years, we saw the Middle East respiratory syndrome emerge. And this came from bats as well, but it came through the vehicle of camels. And they have these camel kissing competitions, who has the most beautiful camel in the Middle East. And this virus is not as transmissible either as COVID-19, but it has caused mini epidemics in places like South Korea. And it appears now that this virus is pretty much endemic in camels. And true to form, this virus has also come into the United States. We've had cases here in the United States as well. So, you know, the world is a village at the moment, and diseases can very quickly be transmitted from one country to another. And I think the early stages by which we were banning flights coming in from certain continents was a scenario that none of us 10, 15 years ago would ever have thought possible. So we live in very challenging times. And I've already mentioned to you that bats are a feature, so it would appear in the epidemiology of all these diseases. And now there is intense interest in the virology of bats. In the case of COVID-19, we're not really sure where this virus might have come from. Unfortunately, we recognize that pangolins are trapped in large numbers for food purposes within the Chinese culture, and also as health tonics, etc. And unfortunately, we have to recognize the Chinese taste for such things, unfortunately, is also a conservation interest, a conservation issue, as well as disease issue as well. And unfortunately, the WHO team that has visited the area where they think it might have emerged from, in other words, southern China, they haven't come up with any great answer at the moment. And it's possible we may never know the exact source, but the probability is that it came out from bats in the first place. So what is the take-home message for you? As a student now going into the workforce, can you contribute to the SDGs through One Health? Well, absolutely yes. And I'd suggest that you can put your specialization here, because honestly, controlling disease now is very much a function of understanding, first of all, the molecular virology. And for that, we now need big data. For Kelsey, for example, with her background in computerization, then you're probably quite familiar with handling big data. And big data is essential now to understanding epidemiology and the way in which then we impose disease control policy and things of that nature. So there is a role for everyone, one might say, within the One Health movement. And these are some of the students that I've been involved with and professionals over the course of time. Charles Noki was a person at one point I was working with in Uganda, and he was involved in the Ebola outbreak there, the Bugia outbreak of Ebola some 10 years ago. So there is certainly, if you wish, an opportunity to follow a One Health pathway. You can get a master's in One Health, certainly here at the University of Florida. And then all these different organizations in one way or another are very much involved in One Health. So don't take that first letter of rejection as something that you can't follow up on. As in fact, Susan was mentioning, you know, go along and present yourself to these agencies and say, you know, I want a job. Can you help me? And what you essentially have to do is act. It's the same message here. And change is not going to come if we wait for some other person or some other time. So challenges for the future. Well, I think that One Health is a call basically for mankind to re-engage with nature, address some of these mega concerns of pandemic disease and food security. And obviously 2050, or around about that point, is a critical point because we need to control our own population. Definitely the ecosystems of the earth, and water is just one example of that, are under pressure at the moment, but the earth's going to survive, and I would argue that we're going to do that as well. But I think we have to go back then to Charles Darwin and point out that it's not the strongest of the species who survive, nor the most intelligent, but those that are most responsive to change. And in that context, the fact that FAO, WHO, OIE, which is another organization outside the UN, and the World Bank working together, this provides enormous momentum now for addressing the UN and this particular goal, but also many of the other goals, in fact, of the SDGs. And at that point, I thank you very much, and I will close down the presentation, and we'll see where we go from here. Now, how do I, here we go, we end that. And now I bring up, I've lost everyone at the moment. That's why I'm talking to myself.
We're still here. Thank you so much for that presentation. I really enjoyed the integration of the food security SDG, which paired really nicely with Dr. Elliott's inclusion of water security and gender equality, but also hearing about, like, very specifically information about how diseases transfer from animals to humans, which I think a lot of people got really confused about at the beginning of the pandemic when people were saying, oh, it's from bats, it came from bats. And my dad is certainly one of those people who is who tends to lend an ear to things that may not be and have any scientific basis just because somebody is really good at making an argument for it. So it's really great to hear, like, clear information about how these things work, how they've always worked.
Well,
So I can use it in a fight.
The trail is very cold at the moment as to what the exact source will be. There's a technique called the molecular clock, when you can estimate when a virus or how long a virus has been outside that original host, if it were a bat, and that would indicate that it might have come across from bats into an intermediate host probably as 40 years ago, and it might have just been ticking over in the meantime before it actually then made its transition into people. So there are a lot of very, very clever people out there. And as I said, the way in which now we can look at molecular evolution in viruses, and that's dependent upon all this machine learning and big data and everything else. And I'm sure that Susan might agree with me that these molecular, we used to call them gene jockeys, but that's probably a rather derogatory term. But the knowledge that molecular scientists have now is unbelievable. It really is.
It definitely is. And I absolutely agree with you about the importance of mathematicians in helping us understand the distribution and diffusion, because we need to know not just where this disease is and where other diseases are, but where they're going. And that's where the mathematical modeling can be so very useful.
And that takes us back to John Snow and Farr. And
absolutely.
That was basically the first time that maps were probably being used to address epidemiology and control. And obviously, you know the story, Kelsey, about taking the handle off the pump. And if you go, there are some great pub crawls in Britain because DNA was announced in the Eagle. Francis Crick and James Watson went to the local pub called the Eagle and announced that they had broken the code for DNA.
I didn't know that. That's amazing.
Yes. And then obviously, if you go to find the pump in Soho, there is now a pub there called the John Snow.
The John Snow pub. I've been there.
Yes, that's right. And was the pump there when you went?
No, there were condos under construction, and they had taken the pump out to protect it during construction.
Exactly, and that was my experience.
That's,
yeah, and
so I have to go back. Yeah, I have to go back.
But you can see that Susan and I go down these rabbit holes, you might say, of places, and we go to them because that reminds us how important many people are in our past who have contributed to our current understanding.
Well, and especially as a geographer, you know, we understand the importance of place to health and how people interact with those places. I mean, the most fascinating thing about John Snow is that, you know, germ theory had not been discovered yet.
Correct.
And the one thing I love about that book, Ghost Map, is it talks about how he filibustered the London City Council to try and get them to cut the handle off the Broad Street pump, because he got a lot of pushback and they kept saying, no, it's not the water. No, it's not the water. Don't be ridiculous. And so he filibustered the London City Council. He kept them up all night just talking and talking and talking. And sometimes I don't think they really believed him. They just wanted to shut him up. Say, okay, fine, we'll cut the handle off the pump. Just stop talking.
And I think, if I may interrupt you and say, the other thing one has to learn is that whatever you're talking about, you are talking about money.
Mm-hmm.
Because I think there were two companies supplying water, weren't there?
Yes, there were. Yeah.
All right. And the pump that was supplying water that was contaminated was being pulled out from the lower area of the Thames as opposed to the upper.
Yeah.
And it was cheaper water.
Yep.
So, yeah.
It's like Flint, Michigan, isn't it?
Yes.
How to get cheaper water, and then you end up making your population sick.
That always seems to be a sort of cycle of how things are changed and how laws are made. Of you suddenly realize this terrible thing people were doing to get something for cheap, and then you realize we should stop doing that, and then they find something else.
But then we never do. You know, it's like when I talk about the water situation in a global context, I always remind people that in Canada, 1% of our population does not have access to safe water and sanitation. And that's a small percentage, but it's a large number. And they are our population, which is already marginalized because they are our First Nations peoples, our Indigenous peoples. And the example I use, and I hope I don't offend, but in the United States, when COVID first came out about this time last year, 90 major municipalities had to pass legislation to force privatized water companies to turn water back on in low-income households that had been cut off because people couldn't afford to pay their water bills.
Really?
And so Atlanta, Chicago, New York had to pass legislation to allow people to have water to wash their hands during a pandemic. Water is a human right. The UN declared that over 10 years ago. And yet you have companies that have the right to say, oh, you can't pay your bill, we're going to cut you off.
Yeah, we've been having issues like that, issues related to that, since the pandemic, before the pandemic. Pretty much every person I talk to about the issues that have really been exacerbated during the pandemic have always said it was a problem before. It was easier to ignore.
Yeah, the pandemic has simply shone a spotlight on these things. And I know in the Canadian context, I'll just share this story. You know, we really are short on vaccines. There's no question, because we have no internal capacity to produce vaccine. We're a huge country, but we're a small population. We're only 37 million people in the whole entire country. And so we prioritized who gets the vaccine first, right? So it went to people in long-term care homes, and then we started with age groups over 80, over 70, and then after that we privileged Indigenous peoples, 16 and above. And so Indigenous peoples started to get vaccinated before the rest of Canada, and there was a lot of pushback about that. But from an equity perspective, as opposed to equality, it makes very good sense.
Absolutely. We've spoken several times with the Abenaki Misakoi chief around here, Chief John Stevens, and he spoke to us all the way back in November about it was a panel on Indigenous peoples and issues related to that, but he was talking about, because almost every conversation these days I have always leads back to the COVID in some capacity.
Of course.
And he was talking about how he'd just gotten the first, vaccination, and he was talking about how Native people and First Nations people have almost always been, one of the worst in terms of people who get hit by things like this, by water shortages, by food scarcity, by pandemics. And the numbers, I kept a track of it afterwards because I was curious if it would keep up, and it absolutely kept up. It was like 2 or 3 times more likely for Native people to get a severe case of COVID than it was for Hispanic people, for Black people, for white people. And there was certainly an amount of disparity between those groups, but Native people far and away were the worst in terms of getting hit.
And in the
it stayed that way.
Yeah, in the Canadian context, we know that there is a difference in life expectancy between Indigenous peoples and non-Indigenous peoples of between 10 and 15 years. So that's the first sign that there's some major inequalities in health happening. And so, of course, they're going to get hit harder because they're already experiencing inequalities in health in terms of, access to nutrition and other major social determinants of health.
But the big concern I have is that we'll just go back to everything as it was before.
Absolutely. And so when people talk about bouncing back, we don't want to bounce back, right? We don't want to go back to where we were. We want things to be better than they were before. Because
the community that works with emerging viruses has been saying all along, this is going to happen. This is going to happen. COVID really, it wasn't a surprise. The good news, and I have to be careful how I say this because people misinterpret it. The good news is that COVID has not killed as many people as it could have.
Absolutely.
And in some ways, you could argue that if it were even more lethal, then in fact, we might have addressed it better.
Go ahead.
I was just going to say, it's interesting when you bring up SARS because the hotspot for SARS in Canada was very close to where we did a study. Both of the seroprevalence for SARS and, West Nile virus, I'm talking about West Nile virus, seroprevalence for West Nile virus as well as behaviors, right? And people were terrified of West Nile virus when it came because it was like, oh my gosh, are we going to have malaria? But they still didn't take any personal protective behaviors. When SARS hit, it hit Toronto, right?
Yes.
So the major
you had a super spreader there.
And I remember you could shoot a cannon off down the main street of Toronto, and in order to bring people back to Toronto, it was insane. You could fly to Toronto for the weekend and get tickets to plays tantamount to Broadway shows and get free bottles of wine and dinners and nights in hotels and everything for like $100 Canadian. It was absolutely ridiculous. Nobody would go to Toronto. We really enjoyed it because we got such great deals, but it almost killed the city of Toronto.
Yeah,
and the prime minister at the time came to Toronto and ate at a Chinese restaurant in Chinatown to prove to the Canadian population that it was safe. SARS was a real wake-up call for Canada. In Canada, until SARS, we did not have a national public health agency.
Okay.
That's the only reason we have one is because of SARS.
Yeah. Yeah, and the WHO director at the time essentially advised people not to travel to Toronto, and the mayor of Toronto, had a fit over that.
Yeah, for sure he did.
Then fast forward to COVID, and it has been so different. Except here in Florida, where DeSantis, our governor, is more or less saying, "Hey, come on down. We need tourism." So what if a few people die? So that's morally repugnant to me, I must admit. So yeah.
Well, I must admit it's fascinating to me to watch Texas as well, and what will happen 2 weeks from now after the stadiums were filled at the baseball stadium? Are people going to die? What is happening in the hospitals? I know here in Ontario, our hospitals are full. If somebody had a heart attack right now, there's no bed for you. The beds are full. So what's happening in places where there are no restrictions in place? What's happening to the healthcare system?
Well, the only good thing, of course, is that statistically young people do not have so many serious complications as the older generation.
Well, I will share with you that in Ontario right now, where I am, which is the most populous province, it's the opposite now. We are hearing physicians telling us that it's 20 and 30-year-olds who are in intensive care.
Yeah, I would agree. I wouldn't disagree with that, Susan. But at the same time, as a percentage of that population that's infected, it's probably less.
I hope so. I really hope so, because my worry, and we're just having a lovely conversation now, Kelsey. I hope that's okay with you. But my worry is the long-term impacts, right? The Guardian posted today about a study done in the Lancet that showed 1 in 3 impacted will have been showing a psychological or neurological sequelae 6 months after COVID. 1 in 3.
And that's because of some of the receptors for COVID-19 are in the brain. My wife reads The Guardian and sort of translates everything for me as well. I do the New York Times and she does The Guardian. Yeah. Any questions, Kelsey? And what about Taylor and the person on the line that is unnamed?
Taylor does have her hand up. Go ahead, Taylor.
I do have a question, and I'll turn on my camera so I can actually
be
a person. So yeah, I know this is going to be a very broad question for maybe both of you, but if there was 3 things that we as humans could do to prevent the big one, what would it be? Because this is evidently not the big one, not the big pandemic. So what would we have to do to beat that, or is it inevitable with our population density and as it is and all of that?
Well, shall I go first?
Yeah.
Okay. The first thing is preparedness, and that's where we've been lacking. If you actually go back to the 1960s, which you might think is a long time ago, but for some of us isn't that long ago, there was an individual called William Stewart, who at that time in the States was the Surgeon General. And at that point, we could see probably that smallpox was going to be eradicated. We had antibiotics. And in general, the world was pretty quiet when it came to infectious diseases. And William Stewart said, hey, guys, let's not worry too much about infectious diseases. It's over. We've got vaccines, we've got antibiotics, and let's now focus on cancer and obviously smoking, things of that nature, which you still see in the World Health Organization list of things that they should be addressing. And we should also be looking at cardiovascular disease. And what that set up was, in fact, a decay in many ways in preparedness for infectious diseases. We'd always been fearful of infectious diseases in the past. And to really repair that neglect that occurred from the 70s right through to really the turn of the millennium, we have not been investing in public health. In the United States, we have not seen an integrated form of public health. And countries that have got, for example, universal health care, and for all my criticism of the Brits and how they've handled COVID initially, they do have a national health service, and the data that they can produce and how they can immediately target the population through the general population is actually very impressive. So, Taylor, the most important thing is actually to have preparedness. And preparedness is beyond just manning the borders and having intelligence coming through from, let's say, embassies. I don't know whether you know, but in terms of veterinary disease control, in the major embassies around the world, there's usually an agricultural attaché, and sometimes it's a veterinarian. And their role there is to, in fact, supplement what is coming through on the agreed international rules of freedom of information, that they actually also report on what's going on in the country. And that's the early warning system. With people, of course, it's much more difficult because people move so frequently and there aren't the restrictions that we can impose on animal populations. But preparedness, communication, that's all important. And then we have to say that we need to make sure that people appreciate and to some degree understand science.
Yeah, I would have said exactly the same thing. I would have said, you know, we need to focus on basic public health stuff. For example, I eat healthy, I exercise. I don't think I'm going to live forever. But if I do get sick, I want my body to be as prepared as possible for some invasion. So we should be doing that at the population level. when Boris Johnson, soon after he got out of the hospital after he had COVID, he started focusing on obesity and public health measures around obesity. And at first I thought he was just trying to deflect. And then when I actually looked at the literature and saw the relationship between the adverse consequences of COVID-19 and obesity, which is a huge public health problem that we've really been ignoring, then I understood. So having a healthy population to begin with, focusing on those social determinants of health that include, and I would say this because I'm in Canada, universal health care, free of financial barriers. So universal health care, good public health measures, a healthy, happy population, like focusing on social determinants like social capital, giving people a sense of community. But then the other thing that and that preparedness piece, but the other thing that I would say is absolutely communication about science. One of the biggest problems, we're doing a big research program right now with women with lupus. And why are we doing that? Well, we've been doing research on women with lupus for a while. And at the beginning of this, women with lupus, because most people with lupus are women, were incredibly disadvantaged. First of all, lupus is an autoimmune disease, right? So they're at risk. Secondly, stress is one of the greatest triggers for flare-ups in women with lupus. So now they've got an autoimmune disease and they can't leave the house, so they're stressed out. So now that's making them sicker. And then Donald Trump said hydroxychloroquine is the #1 drug that's going to cure COVID for everybody. Hydroxychloroquine is the #1 drug that keeps women with lupus alive. All of a sudden, there were global shortages in the drug that kept them alive. And like literally in provinces in Canada and Quebec, they ran out. In Spain, they ran out. We heard stories in the US that women that were paying $100 a month for their drug, it went up to $1,000 a month. So now they're triply stressed. So we actually did, we surveyed women in the US, Canada, Spain, and the UK, Mexico, Singapore, and Korea on where they get health information from during a crisis. Where did you get it before the crisis and where did you get it during the crisis? And then we're working with patient support organizations to say, this is the kind of information people need and this is the form in which they need it. Because I really think it's the knowledge mobilization. It's the scientists who are saying, we know how to create the vaccines. You social scientists need to be able to figure out how people are going to be accepting these vaccines. There's an amazing organization in the UK called Making Sense of Science. It's a national trust, and they produce fantastic work on helping the average person understand what science means. They have this amazing document on their website that talks about statistical significance. How do you explain? So if you got to choose, you know, we've had this issue with the AstraZeneca vaccines in Canada, right? With the blood clot issue. How do you make those decisions? How do you communicate? It's okay, trust us. You heard that stuff about blood clots, but it's okay. You can have this vaccine because this is what it means. How do you explain to somebody who doesn't have that level of education, what is statistical significance? They have an amazing document on what is peer review, because we hear all these things in the media, right? Well, they say that, but it wasn't from a peer-reviewed paper. It was just from a report. Well, what does that mean? And so being able to raise scientific literacy, but also being able to, I don't think we will ever be able to teach bench scientists how to explain their science to the public, and I don't think they should have to learn. But what I like is that there's this emerging middle manager, if you will, called a knowledge broker, who can understand the science and know how to communicate it to the public. That's what we need more of. You're absolutely right. One of the first panels I ever watched, one of the first webinars I ever watched during COVID was a whole bunch of bench scientists who were creating vaccines. And when the interviewer said to them, okay, so what's the thing we need now? Every single one of them said, we need social scientists who can explain this to people to remind them that they need to have this vaccine and this is why.
One of the problems, unfortunately, though, Susan, and I'm involved with, I don't know whether you know the program ZELS, Zoonosis in Emerging Life. Well, Joanne Webster. Do you know Joanne Webster? Okay, she works on schistosomiasis. Anyway, okay. One of the, Alzheimer's disease suddenly hit there. What was I going to say?
How do we mobilize the science? How do we do knowledge mobilization?
Oh, yes. Social scientists, all the projects, and ZELS is a program that is in the developing world, but it's supported by the British government. It's about $30 million. And the problem that we have been facing as the advisory board, is that the social scientists never actually put forward the proposals that get funded.
Yes.
And they're always acting or they're in a supportive role as opposed to a primary role.
Yeah.
And the big issue is,
no, you're absolutely right. And it was interesting. Kelsey was saying early on that I was part of the Allergen NCE, which is a 15-year research program on gene-environment interactions in the production of allergic disease. I am the token social scientist, and the only reason I'm there is because the government said you can't have the money unless you have a social scientist on your team.
Yeah.
So yeah, that's how it works. Is our time up now, Kelsey?
But but I don't know whether you follow the UK research initiatives, but they are very much putting a lot of money internationally into social science as it relates to epidemic disease.
Yes. Yeah.
Which,
no, they do a much better job than we do. That's for sure.
Oh, and definitely a lot better than we do here in the States at the moment. We're sounding as if we almost support the British at the moment, but let me assure you, there are lots of problems in Britain.
Yep. There are advantages and disadvantages everywhere.
Yeah.
All right. Thank you so much. I believe that is time. Unfortunately, we were having a great conversation.
That's awesome.
Thank you both so much.
And thank you for
Thank you.